so without further ado, I will let him take it away.
Thank you. As mentioned, my name is Brian Blackburn. I'm an orthopedic spine surgeon. I'm with Complete Spine Care. My partner is Travis Lloyd-Dolt. I've just moved to the area recently, so I just want to thank you all for coming and allowing me to speak to you tonight. And hopefully we can answer any questions or concerns that we may have about this particular topic. I know everybody's very busy, so I appreciate you taking the time out of this evening to spend the time here with us. So our topic here today is low back pain, and really it's largely about our treatment options, and particularly those of fusion versus arthroplasty. But we'll go over a plethora of symptoms, a plethora of diagnoses, and essentially getting to these various treatment modalities. So an overview of our discussion today, we're going to talk about some of the epidemiology to low back pain, some of the anatomy of low back pain, the causes of low back pain, how the patient may present or their clinical history, some of the imaging studies that we're looking for and what those imaging studies may indicate and why we're ordering them, some of the various treatment options, and those can generally be divided into those of non-operative versus operative intervention, and we'll get into some of the specifics of that as well. So with regards to anatomy, some of the basic anatomy is primarily of the lumbar spine is 5 lumbar vertebrae, and there's various vertebrae throughout the body. Generally we think of that in 3 different segments: cervical, thoracic, lumbar spine, and then in getting into the pelvic structures, including the sacrum, which is kind of this junction between the pelvis and the axial spine. But largely, again, speaking of the lumbar spine here this evening, that's 5 lumbar vertebrae, but there is some variation of that. So sometimes you may present to the clinic and we can see that there's only 4 lumbar vertebrae, or perhaps 6 lumbar vertebrae, and sometimes even some transitional anatomy. And that's not really of critical importance, just something to note that something that we can see from time to time, and sometimes that can be indicative of particular processes that are going on in the spine as well. But essentially, the most critical component of this is what we call the spinal functional unit. So the bone, disc, bone is how I like to think about it. More often than not, the pathology exists at the disc level of the spine, and that is compounded by the joints in the spine as well. So when the disc begins to degenerate, then the joints of the spine also begin to degenerate, and that's this cascade of events. Generally, the disc degenerates, the joints degenerate, and they can no longer support one another, and then there becomes this vicious cycle of propagation of one problem onto the other, and eventually that will propagate to other adjacent segments, both above and below the primary level of that problem. This cartoon helps to illustrate some of that as well, particularly if we're looking at this segment. This is more like the axial view of the spine. So this is the joint, and when that joint becomes affected, that can really be indicative of what kind of treatment modalities we have, and particularly some of our largest decision making with regards to spine fusion versus total disc arthroplasty, and that will become important again later in the topic this evening. So some basic facts about low back pain. The prevalence of this is quite high. Most people have experienced low back pain sometime in their life. I'm sure most everybody in this room, we're all here for a reason, have experienced something like this. That can be something as severe as a major fracture or a major trauma, as something as small as a muscular strain or a ligamentous sprain. But most people in their life will have some episode of back pain. Most of those folks will also resolve that back pain in a relative short period of time, usually in 3 months, and almost everybody at the 1-year time frame. But there are some that develop a chronic pathology or chronic back pain, and that's about 5 to 10% of people that have a chronic low back pain scenario. It's the #1 cause of disability in the world, so we recognize that the prevalence of that is quite important, and it can have quite a large socioeconomic impact as well. I saw a couple different figures of this when preparing for this talk. One mentioned $100 billion per year of essentially socioeconomic costs, and another up to $300 billion per year. So we recognize, most importantly, from a humanitarian perspective or humanistic approach, we're treating the patient, but we also recognize this has larger sequelae in the overall socioeconomic world as well. Common risk factors that we see for low back pain: obesity, smoking, generally poor health, and or repetitive motion, and those folks that are involved in manual labor. When we talk about low back pain symptoms, many times we divide this into two broad categories, those of axial pain and that peripheral or neurogenic pain. Axial pain, I generally think of more of, again, that spinal functional unit, the bone, the discs, the joints, the actual structural component to the spine. Whereas the peripheral or their neurogenic side of things is more of the neurologic. Are the nerves being compressed? Is the spinal cord being compressed? And generally the former is more what we're talking about today, more that true back pain scenario. Whereas the peripheral etiology or those causes of back pain, more often than not, that is neurologic in origin, and sometimes that can supersede some of the low back pain scenarios. Particularly these other conditions like myelopathy, which is spinal cord compression, cauda equina syndrome, which can be a surgical emergency, and spinal cord injuries. Those, that particular problem will be treated in a more urgent or emergent basis. So some of the causes of low back pain, as we touched on, musculoskeletal causes. That's generally the bone, the disc, the surrounding musculature, something again as simple as muscular strain or ligamentous strain. And then you can get into some more of these structural components, such as compression fractures, where the bone will actually fracture and compress, generally in a wedge type formation, or instability, where the spine actually shifts on one bone on top of the other, and or spinal deformity, or fractures which can cause significant instability. And then we also have to think about some of the systemic or the rare causes of back pain. So more often than not, the more common things that we see are degenerative nature, traumatic in nature, but occasionally we need to look for some of those more concerning causes such as cancer, infection, or like a systemic inflammatory or autoimmune disorder. If we look at back pain, we have to look at some of these risk factors that we touched on: obesity, smoking, osteoporosis. All of those put us in line for a potential increased likelihood of having a back pain or a chronic back pain scenario. But we also want to look for some of those red flags to make sure we're not missing any of those more concerning findings. And those red flags many times are things like fever, significant weight loss, IV drug use, and if those things are present, then that may put us down a different treatment and or diagnostic algorithm that we need to look at. But for the most part, we're looking at more of a degenerative disease in the spine. So what are the symptoms of low back pain? As simple as it may sound, pain in the low back. More often than not, patients will present with pain across the lower portion of the lumbar spine, kind of at that lumbosacral junction. That can be aching, stabbing, or a variety of other symptoms that the patient may describe their symptoms. They can be stiff. They many times have difficulty with transitional maneuvers, going from a seated to standing or standing to seated position. And then occasionally that pain can radiate to other areas in the body as well, down the legs, which is generally more radicular of the nerve origin and or like a referred pain pattern, which can be coming from a different area but mimicking some of those nerve type symptoms. So when we see the patient in the clinic, one thing that we want to do is obtain some diagnostic studies. That is largely based on radiographic imaging. More often than not, by the time they get to a spine surgeon or someone in a specialized field, then usually they'll have a lot of this already completed, which can be advantageous for us, and then we can hopefully assist in the diagnosis and treatment algorithm. But if not, generally we would begin with things like x-rays. X-rays can give us a very good structural evaluation of the spine. They can tell us if there's instability, again, if there's shifting of the spine. They can give us a pretty good outlook to determine if there's a fracture in the spine, and overall a very good representation of the spine, as well as x-rays are a very good comparison. So intraoperatively versus preoperatively, and we can usually obtain those imaging studies pretty readily, pretty quickly, and pretty cost effectively. An MRI is usually used as an adjunct to that. That's a better look at the neurologic structures, particularly the spinal nerves, the spinal cord, and many times we also utilize that for evaluation of the discs. Such as this particular MRI, we can see that these discs actually look really healthy. They're nice and have really good water content illustrated by that fluid or that signal in the lumbar disc. And we can see that when this begins to become disrupted, we can see disc bulges, we can see desiccation or drying out of these discs, and those can all be indicative of a problem and potentially the source of the back pain. However, with that said, we also recognize that many folks have abnormal MRIs, and that does not always directly correlate to the symptoms. So that's why it's really critically important to correlate the patient's symptoms, history, physical exam to the radiographic studies that we've obtained. With regards to treatment for this, usually beginning with the lesser invasive and the lower risk procedures, such as simple education with the patient, activity modification, staying away from the things that are troublesome to you, but hopefully continuing to maintain mobility, strength, and structural integrity to the spine. If that's enough, then perhaps that's all that we have to do. But more often than not, we need to ascend in that pathway, then generally referring to physical therapists that can help you with some of those modalities, some of the strengthening, some of the core exercises, balance, and some of that proprioceptive evaluation and treatments. And hopefully, again, that can get you to a better quality of life where you can enjoy your life without having to pursue any intervention. If those are still not enough, then generally we would again ascend to more intervention pathway, and that's generally beginning with things like injections. Those injections can be numerous. They can either be injections into the muscle, generally considered trigger point injections, spinal, epidural spinal injections, which are steroid injections into the spinal canal. That's usually a strong anti-inflammatory to calm the over-inflammatory response, and sometimes injections into the joints of the spine that are generally geared more toward the actual back pain scenario. And again, if that is adequate, then generally we would stop there and continue with our life and hopefully be able to do so without any surgical intervention. Unfortunately, if that is not enough, then sometimes we have to consider surgical intervention, and that can be numerous in a variety of different modalities and techniques that can be used. However, with that said, there are some scenarios where we don't always go down that typical algorithm in which we feel that if we did that, then that could put us at higher risk for having further problems down the line. As we can see here, this is an MRI that demonstrates evidence of a relatively small disc herniation, but a disc herniation nonetheless at the bottom segment of that spine, L5-S1. That can be quite debilitating and can certainly change someone's life, but at the same token, more often than not, this can be treated in that algorithmic approach from least invasive to most invasive. Whereas in this other scenario, we can see this is certainly a different scenario altogether. A very severe trauma, fracture dislocation with spinal cord transection, this certainly would not be amenable to that more progressive approach to treatment of the spine. This would certainly require surgery right off the bat. With regards to surgical intervention, as we touched on before, these are generally divided in a couple different categories. Those of decompression, which is essentially opening up the spinal canal to allow those nerves to have more room and to function appropriately, versus that of a spinal fusion, which is more of a stabilizing procedure. And there's various approaches and techniques that can be utilized for that. And finally, lumbar disc arthroplasty, which has kind of a smaller sub-segment and a narrower window for indications, which we'll touch on in a moment here as well. So when is surgery needed? So as we touched on before, if you attempt all those non-operative measures and you've not had the success that you want, and our imaging studies, clinical history are all correlate with one another, as well as the patient desires or wants the surgical intervention, that's generally when a surgical intervention would be considered. Other indications would be if you have progressive neurologic decline. So sometimes those are the scenarios which can be a bit easier from a decision-making process, because if we don't intervene, then there's a likelihood that we could continue to progress, worsen with time, and we recognize that that intervention should stop the progressive worsening in hopes that it will provide the patient with a better outcome. And hopefully that would be the appropriate choice if necessary. Other indications be if there's instability to the spine, where the spine is shifting, or a condition that we call spondylolisthesis, and or major deformity to the spine. So those would be stronger indications for intervention, usually in the form of a spinal fusion. So choosing candidates for spine surgery, these are all the various factors that play a role in our decision-making process. Those of age can certainly help us to indicate whether the patient's an appropriate candidate for a decompressive procedure versus a fusion procedure versus an arthroplasty. The facet arthrosis, or the arthritis in the actual posterior joints of the spine, which is what we touched on, kind of one of those first slides, that can really be indicative or can help indicate which type of surgery we may need. And really for the lumbar disc arthroplasty, these top several categories is what we're looking for, somewhat of an inclusion criteria, whereas these bottom ones are ones where we would rule out that particular treatment as an option. So if they've already had a fusion, if it's a revision surgery, severe osteoporosis, instability, fracture, those would not have a good indication for disc arthroplasty. So with regards to a fusion, as we touched on before, this is usually done in the form of screws and rods, as we would say, and sometimes can be performed with what we call interbody devices. So we can see that on this picture on the left, these metal spacers are placed into the disc space to hopefully replicate the typical size, shape, and structure to the disc and provide appropriate alignment to the spine to give the patient the most appropriate sagittal alignment and coronal alignment, which translates to good overall outcome. And again, fusion is generally indicated in those patients that have the shifting or the instability, a major fracture, severe stenosis that with simply a decompression would likely not be adequate for the patient, or with really advanced degenerative disc disease. I also wanted to just illustrate that there can be quite a variety or quite variable indications for spine, as well as the extent that can be done. So these are both fusion procedures, but you can see the one on the right is certainly more involved and extensive than that on the left. But nonetheless, both still pretty big surgeries. So when a lumbar disc replacement, which I think is probably the primary question that we have here tonight. So the indications for this would again be if you are relatively young, without the facet disease, without a major contributing component that the arthritic change of the joints themselves are causing a problem, and no instability and no osteoporosis. So many times when we get to this particular decision-making arm, we have ruled out a lot of those things, because some of the stronger indications are those really that are indicated for fusion: the instability, the severe disc space collapse, the spinal stenosis. But lumbar disc replacement is a very good procedure for those that are within this narrow window of treatment. So what is a spinal fusion? Essentially, spinal fusion is linking those bones together. That can again be done in a variety of ways, but linking from one segment to the other. That can be done across the disc, as we can see, such as this model demonstrates here, or even in what we call these transverse processes. But essentially, our goal is to link one unit or more, depending on the number of levels that we are deciding to fuse. This is an illustration to demonstrate the variety of techniques and approaches that can be used for the spine. And that can be quite extensive, and again, can go from the anterior approach, an oblique approach, a lateral approach. This is what's called transforaminal or posterior. These are all fusion procedures, all essentially achieving, or our goal is to achieve the same thing with spinal fusion and placement of an interbody device into that disc space. There are some techniques where you don't have to use an interbody device either, but nonetheless, the goal will be to link those bones together more often than not with screws and rods, and providing for a solid bony union between those segments. With regards to the lumbar disc arthroplasty, I think this slide's a little bit backwards. With regards to the lumbar disc arthroplasty, this is more of a motion preserving procedure. So this does not gain motion necessarily, but it will preserve the motion that we have. Whereas with a spinal fusion, we're actually removing the motion of those segments that we're fusing. So this is really beneficial in that this can maintain the range of motion for a patient at that particular segment. And probably one of the biggest advantages is that there's a decreased likelihood of having adjacent segment disease. So when we fuse the spine, the bones are linked together, and then those forces are transferred both above and below that prior fusion construct, and that can break that down, and then that's when we may need more surgeries in the future. Whereas with this particular procedure, that decreases the likelihood of that, albeit still present, but significantly less, and therefore less likelihood of needing additional level surgery or adjacent segment surgery. To back up one, this was just some of the initial studies that were done for the investigational component of the lumbar disc arthroplasty. There were several that were on the market in the past, but as time has gone on, many of those either never actually got all the way to FDA approval or were removed. So currently there's only one disc that's approved, and this is the ProDisc L. This is by one particular company called Sentinel Spine, so it's the only disc that's on the market currently. And it's actually approved for 2 levels, whereas before it was only approved for 1 level of lumbar disc replacement. From a technique perspective, relatively similar to a lumbar spinal fusion, particularly from an anterior approach. So lumbar disc arthroplasties have to be approached anteriorly. That's the only way that it's done currently, through what's called retroperitoneal. So an incision from the front of the belly, either that can be vertical or transverse, going down to the spine, retroperitoneal, behind the peritoneum, which houses the intestinal contents, and then access to the spine itself. So you can see that this again is a schematic of the surgeon mobilizing that peritoneum or the intestinal contents to access the spine itself, and then this is a cartoon of the implant of the disc replacement itself. So we want good visualization so that we can put our implant in the appropriate position, which is again confirmed with radiographic imaging studies intraoperatively as well. With regards to recovery and rehabilitation, for the most part, I think that these are pretty similar, but as a whole, lumbar disc arthroplasty tends to be considered an easier recovery, a little bit quicker recovery, and tends to be quicker return to work. Some of that I think is because the procedures tends to just be smaller as a whole. Usually it's only done from the front. It is usually only one level, sometimes two, whereas we saw with that prior x-ray of the lumbar spinal fusion, that can be quite extensive from the front, from the side, from the back. So it's a bit of a different animal, but nonetheless, as a whole, lumbar disc arthroplasty is considered to have quicker recovery and a bit easier recovery. I plugged this into one of the AI tools just because I was kind of curious as what it would come up with, and this seemed to be pretty accurate. So I think that this is pretty consistent with what we've seen in the literature. The hospital stay for both these procedures tends to be anywhere from 1 night to 3 nights. Both procedures want to get you up and walking right off the bat, be as active as we can. The spinal fusion, however, we would generally brace you. We would want to restrict the range of motion for a period of time, anywhere from like 6 weeks to 3 months, and that can be somewhat surgeon preference as well as patient dependent, and the extent of surgery that was performed. Return to work, I personally think that both of these are a bit early. I generally say no return to work for no earlier than 6 weeks at absolute earliest for spinal fusion, probably more like 3 months, and probably something similar for lumbar disc arthroplasty, maybe on the shorter half of that, more like 6 weeks or so, depending on what type of occupation that the patient does. With regards to physical therapy, lumbar disc arthroplasty tends to initiate a little bit sooner because we want to maintain the mobility to the patient, whereas with a spinal fusion tend to be a little bit delayed because we want to allow those bones to heal a little bit more. In either regard, the complete recovery for a spinal fusion is about a year, and with a lumbar disc arthroplasty can be quoted anywhere from like 3 to 6 months or so. So definitely a little bit quicker from start to finish for an arthroplasty. This is pretty similar. Also asked AI just to see what they thought with this. Overall, about the same and similar answers. So I think when we're comparing these two, the biggest points are what's the motion of the spine. So a lumbar disc arthroplasty has preservation of motion, whereas a spinal fusion is a stabilizing or removes the motion from the segments that are fused. Pain relief and mobility, they're about the same long term. The mobility, of course, may be preserved with the lumbar disc arthroplasty arm of these patients, but long-term overall outcome are about the same for these patients as well. Initially, the disc arthroplasty tend to do better, but we feel that as time goes on, the fusion group kind of catches up as they become more stable, and the lumbar disc arthroplasty tends to have a little bit of waning results as time goes on through their recovery process. And of course, the most critical component of all this is the patient selection. So that's, as we touched on before, for a lumbar disc arthroplasty, a very narrow window for indications, and a spinal fusion also should have stronger indications, but a bit more broad in that regard. Pretty similar to what we talked about before. This is a little bit more some of that critical data. I think this was pretty interesting in that both of these did have some evaluation of the adjacent segment, as we talked about before. So some of these studies looked at the adjacent segment of a spinal fusion versus that of a lumbar disc arthroplasty. So those with a spinal fusion had about a 35%, a little bit less than that, adjacent segment disease, radiographically breakdown of those adjacent segments, whereas a disc arthroplasty had about half of that. And then if you compare those that actually would require further treatment, it's about 15% of a fusion procedure versus 1% of a disc arthroplasty. So certainly and significantly less in the arthroplasty group. So complication rate is less in the arthroplasty group, revision rate is less in the arthroplasty group, and as a whole, again, the overall need to revise both that level and the adjacent segment is less in the disc replacement group in comparison to that of spinal fusion. So this is, again, specifically with regards to the implant that is utilized today. This is the Sentinel spine, the ProDisc L. The mechanism of how this works is essentially two plates that are placed in the spine, one on the inferior end plate or the superior level, and the superior end plate or the inferior level, and then these plastic inserts essentially. And this is considered a ball and socket design. So it can mobilize on that ball and you still have all what we call 6 degrees of freedom. So you can flex, extend, side bend, and rotate on your axis as well. And this has been very stable, and the overall outcomes for this have been very good. The ProDisc L studies are probably the most thoroughly studied of all the implants, and again is the only one on the market today. They've demonstrated very good results at 2 months after surgery, 2 years after surgery, 10 years after surgery, and currently have 20-year data that has shown overall improvement of 2 primary measures, what we call the visual analog scale and the ODI. So probably the 2 primary measures that we utilize the most in spine surgery. So as a whole, this certainly has a lot of benefit with relatively little downside. But the challenge to this particular procedure is that the indications and the patient selection is quite narrow. Generally about 40 years old, no recurrent or revision surgeries, no prior fusions, no fracture, and essentially more often than not an isolated 1 to 2 level problem, whereas with a fusion is again more broad in that regard. And a couple other, just kind of talking points here is that overall, again, the satisfaction rate for the ProDisc L is about 90% at 10 years, which is really good, and the revision rate is quite low. Overall, about 1% versus 10% for a spinal fusion, so substantially less. And one thing that I always think is interesting is what is the pre-testing, what is the testing that's done prior to these implants getting out? Because one thing that, as an orthopedic surgeon, we always think about what's the wear, such as in a hip or a knee. More often than not, that has what we call metal on poly or metal on plastic liner, and that plastic can't actually break down, and when that breakdown occurs, that can weaken the bone. Thankfully, that has not happened in the spine, so we don't see a lot of that, what we call osteolysis. So despite having that wear on that plastic, that's still much less of a concern in this regard. So I think that bodes well for longevity of a total disc arthroplasty. And they run these through 10 million cycles, which they believe is about 40 years of wear in a human. So the longevity of this should be about 40 years, if not more. So I thought that was quite an interesting fact as well. And that's it. Any questions? I know it's a lot. Sure.
If someone was to get say a 30-year-old, and they got a disc replacement, but then later on needed a second surgery, how would they get a fusion, and then do you have any outcomes with those, like a
Adjacent segment. So it depends if it's adjacent segment. There is revision rates of the disc arthroplasty as well, although quite low. The concern with that is then you have to go in back through the same approach through the retroperitoneal access by the great vessels. So that increased risk of a potential vascular injury, although that is quite rare, that does increase that potential risk. So if you have adjacent segment disease, you can perform a adjacent segment lumbar disc arthroplasty, but again, still need to meet that criteria essentially. So without the facet disease, without a major instability, fracture, or otherwise. So as long as they're still within that criteria, you can do so.
So, sorry, my question was if they got the disc replacement at 30 years, and at 70 years they were starting to break down. At 70 years, have there been any studies of those people like needing to swap out to a fusion?
Not that I'm aware of. So the first Pro Disc L was implanted in the United States in 2006. So it's really only been on the US market for like 20 years. The first Pro Disc L, I believe, it ever implanted was in Europe in 2000. So 26 years of in vivo data. So that particular question I don't think has been answered yet, but I would say just to extrapolate from what we know now, the likelihood of being a candidate at 7 years old for disc arthroplasty is pretty unlikely, just because you've likely developed arthritic change with a facet disease and probably as a pain generator. And the reason why that's important is because if we look at the spine, if this is front of me and back of me and the joints are in the back, that disc will still allow you to flex and extend. So if you're loading those joints and extension and that's the pain generator, then the patient won't be satisfied because they say, all right, I got rid of this disc that's abnormal, but that pain from the facets is still there. So while you still may be mobile, it still could cause you pain, and that could be very unsatisfied, dissatisfied patient, which can lead to more treatment, and anytime we go in the spine, that can cause other problems. So if we can land on the appropriate diagnosis with the appropriate treatment, hopefully that will provide for long-term good outcomes.
So most of us are ineligible for that.
Exactly, I know, so that can be a challenge. So that's I think part of the take home here is that the lumbar disc arthroplasty is a great procedure, but it's a bit of a unicorn in that that's a pretty rare patient that comes in with that. So most of what I see is folks that are a bit older, these are more degenerative processes. There are those rare circumstances where someone might have, again, a relatively young patient with an isolated problem in their disc. But I think that that's a pretty rare occurrence, unfortunately. So in my practice, certainly do many, many, many more fusions because the indications are much stronger and, again, much broader. Yes?
Do you find that injections help, what are the outcomes are for the reduction of pain, and if so, what do you use as an injection?
So usually the injections are done pre-operatively, and they can be done more or less in two different formats, or almost three. One is diagnostic, in that the injection is placed usually into the joint, so a facet injection, or what's called a medial bundle branch block. So again, placed right into that joint. And that's usually done with a numbing medicine, a lidocaine or a marcaine. And that is really only designed to knock that pain out for like 4 to 6 hours. If that is the case and you have substantial or notable improvement of your symptoms during that time frame, then that is again indicative that those facets are a source of the symptoms or a source of the pain. If that's the case, that can be followed up with what's called an RFA, or an ablation, burning of the small pain fibers that live in the joint. And that tends to be a very successful procedure. I think because you've kind of been set up, we're pretty confident that those joints are the source of the symptoms. Another one that's similar to that is a facet joint injection with a steroid. So the steroid is essentially very strong anti-inflammatory, again placed directly into the joint, and many times that can be beneficial as well, but less diagnostic in the sense, because it's not as specific. So if I a lot of times explain to patients, if I were to inject you in your shoulder, intramuscular with a steroid, you'll kind of just feel better as a whole. So we say, well, is it the shoulder that was the pain? Probably not, right? It's just the steroids that's acting systemically. And while that injection into the joint is more localized, you still have a little bit more diffuse effect, whereas with just the localized injection, that is more specific. Other injections can be placed into the spinal canal, what's probably the most common epidural spinal injection, and that's a little bit broader approach. I would say more often than not, that's more for the leg symptoms, the radicular complaints, because that's targeting the nerves, whereas the joints are more targeting the facet or the back pain itself. Yes?
So, for screws and rods, how long does that typically last, assuming it's like an older person already with arthritis? Does it tend just to make it worse faster?
So hopefully, ultimately, the goal is to get you better, right? And we wouldn't want to perform that surgery if we think there's a low likelihood of that or a high likelihood of having a problem. But the general consensus on that is when we start to fuse the spine, we are again removing the range of motion from those levels. So the adjacent segments, both above and below, tend to break down. Unfortunately, more often than not, some of that has probably already started. So that may advance that in somewhat of a more rapid fashion. But as we saw in one of those slides, we could see that about 30% of people have adjacent segment disease at 10 years' time, and 15 to 20% of them may need an adjacent segment fusion. So it's still a relatively low number, but it's not the lowest number out there, right? So we have to recognize that there's a decent chance that that may occur. And someone that's younger, they have a higher likelihood just because they're going to live longer, and they may be more aggressive to their body. Someone that's older, the duration or the longevity unfortunately may not be as long, but at the same time, the quality or the strength of the bones and the joints could break down quicker, so there might be some scenario there. But in general, the duration of that is as we talked about, but 20 to 30% of people need an additional level at 10 years' time. 10 years, yeah. Similar, cervical spine is a little bit less. It's like 22.5% of people at 10 years' time, probably just because less biomechanical stress in the cervical spine itself. Yes?
Could you talk about similarities, differences between a lumbar disc versus what's used in the cervical spine? Are they the same? What might they be?
Pretty similar. I think one difference is that there's only one implant for the lumbar spine currently. So there's only really one implant that can be chosen, although the data on that is pretty strong. Whereas with the cervical spine, I think there's 3 to 4 currently. The same manufacturer that makes the lumbar spine also makes a variety of implants for the cervical spine. There's one other that's probably the most common, called Mobi-C, but similar in a sense. So ultimately the goal is to preserve the range of motion and to decrease the likelihood of adjacent segment disease. In the cervical spine, the studies have shown that a one-level fusion versus a one-level cervical disc arthroplasty, and the way they term it is an arthroplasty is non-inferior, so it's the same. That's how I interpret that. Whereas a 2-level cervical disc arthroplasty versus a 2-level fusion is superior in adjacent segment disease. But the other symptoms or the other improvements such as radicular complaints and neck pain are about the same. But similarly, still need to look for the facet disease because you still are loading those facets, still a pretty narrow window. But I think as a whole, people have expanded the cervical indications a little bit more so than the lumbar. People are certainly more strict with the lumbar indications as a whole. Yes?
When would you guys consider infusion for a compression fracture versus a kyphoplasty?
So generally not a fusion for a compression fracture. So a compression fracture is technically divided. There's 3 columns to the spine as we divide the anatomy. The anterior column, when the anterior column is fractured or disrupted, that's a compression fracture. That is generally treated with 3 different ways, either observation, bracing, or kyphoplasty. And the outcomes for those are all about the same. It's just a matter of, how willing are we to tolerate some of the discomfort or is that brace too cumbersome to use or not to use. The kyphoplasty tend to have very good outcomes, but it's generally earlier that I feel like patients do better with that. So there's a certain window that would be appropriate to perform a kyphoplasty on someone with a compression fracture. Fusion is generally not done for a kyphoplasty. However, sometimes there is another condition called a burst fracture, which is similar to a compression fracture, but involves 2 columns of the spine, and that tends to have more structural compromise and tends to have more concern from a neurologic compromise too, and that would be a stronger indication for a fusion. However, that still has a bit of a controversial discussion in that some surgeons feel that patients do better with fusion and others don't, and there's certain criteria. 40% of kyphosis, 50% of canal compromise, and or with neurologic compromise would be a stronger indication for a fusion. But as a whole, non-operatively if we can.
I have another question.
Mm-hmm.
So for people who are getting fusions who have disc breakdown versus people who are getting fusions because of a scoliosis component,
Mm-hmm.
how is the outcomes for those patients, being that their spine has a different bit of alignment for you guys, or maybe a little trickier approach in terms of not having everything line up and then having to figure out how to get that fusion to match the adjacent
Yeah, so spinal deformity surgery is certainly a bit of a different animal as well. But folks that have major spinal deformity actually tend to do very well. And a couple thoughts behind that is one is because they're in such a bad spot before. So they have a major jump and a major improvement, which can be a significant difference in the quality of life. There's also radiographic predictors with regards to spinal deformity. Those largely what we look at is for deformity itself is coronal deformity, so are you kind of leaning from side to side, or sagittal plane deformity, are you leaning forward or backwards? And the leaning forwards tends to be the more challenging of those and tends to be more challenging for the patient as well. So if we can restore the sagittal alignment, that has a direct correlation with positive outcomes with surgery, whereas the coronal is not quite as important, yet still important. So that's the deformity side of things, whereas more of like a degenerative component and or instability component, usually focusing on those levels, as long as we can restore the focal abnormality, then patients tend to do pretty well there too. But a bigger jump, and overall people do well with the deformity surgery. It's just a bigger procedure to go through. Yes.
I came in a little bit late, but you
That's good.
already talked about the cysts that grow on the spine, like synovial cysts.
I didn't talk much about the cysts. There's various types of cysts. Probably the most common is the synovial cyst, which is generally or essentially like a little outpouching of a fluid-filled sac. And each of the joints, those facet joints, again, talk about the joints, they're encapsulated, and that capsule tends to stretch out because there's fluid from the inflammatory response. And that cyst and that bulging can go in any direction. So sometimes it's posterior and there's not much back there, so that doesn't really cause any clinical symptoms. But if that is pushing into the spinal canal, that tends to have generally more like radicular features, so leg symptoms, pushing on the nerve root, weakness, numbness, tingling, pain. If you have a cyst and you're amendable or you're willing to try a decompressive procedure, sometimes you can do a cyst resection, and then that will come out and you'll decompress the spine. With that particular problem, there's about a 50% recurrence rate, however. So that's why sometimes with a cyst, we just jump to a fusion, because there's such a high likelihood of that coming back again. Usually I have conversations with the patients, and I try to do kind of what I say, the least amount of surgery with the greatest amount of benefit. So if you have that cyst and we're willing to try that, but recognizing we might have to do something more extensive in the future, then I think that's a good way to go, because you don't know, hindsight, you don't know what would have happened if you went the other way, right? But using that literature, it's about a 50% recurrence rate with the decompression versus the fusion should take care of it. Just to touch on one other thing, there's another cyst in the spine that we see commonly, which is called the Tarloff cyst. So I don't know, that's one that we see a lot of times in the MRI. That's usually in the sacrum. More often than not, those are asymptomatic, but they can be kind of gnarly looking on the MRI and almost impressive, but more often than not, we don't treat that, we just observe it.
Do you see that females get those more than males?
I don't know the incidence of that, but I would say anecdotally, that's probably true. Yeah, I don't know the variation of that though. Any other questions?
Quiet group.
Well,
All right.
I see some familiar faces. Well,
If you are shy and you don't like speaking, Dr. Blackburn will be up here. He also brought cards and information from their office, so please take one if you're interested. And then just a quick note, in May, his colleague, Dr. Woodwhite, will be here to talk on the cervical spine, disc replacements, fusions, same gamut. So for those of you who have two problems going on, maybe you guys will come back. Or if you know somebody in your life who would like to hear this talk, we'd encourage you to come back. But again, we'll thank Dr. Blackburn.
thank you. Gentleman had a question?
Slides available?
I can make them available.
Yeah,
Sure.
well, if you want, he emailed them to us. So as long as we have your email address, we can try and see if we can email them out if it's not too much trouble. Kate, is that too much trouble? Kate says it's not too much trouble. All right, we'll make it happen. All right, thank you very much, guys. Thanks for coming out.
Thank you guys. Thanks for coming.